Yeah, it's 7 o'clock. We're going to start the meeting. Good evening, everybody. My name is Dr. Vemuri Murthy, and I'm from the Department of Emergency Medicine. I'm an adjunct faculty at the University of Illinois. Greetings from the American Association of Physicians of Indian Origin and Chicago Medical Society. I welcome you all to the CME program, Resuscitation Practices, Guidance Updates during the COVID-19 pandemic from the American Heart Association and International Liaison Committee on Resuscitation. I thank you all for participating in this informative and timely webinar involving international resuscitation experts and a cardiologist on the front line fighting the pandemic in the United States. I'm happy that some of the American Heart Association International Training Center faculty and experts from the Indian Resuscitation Council and EMRI and others might have already joined us, or they will join us shortly from India. The speakers will participate in focused presentation of their respective topics, followed by a time-limited question and answer session. We sincerely request you to use chat only for questions to the speakers so that we can focus on the presentations. It's now my pleasure to introduce the moderator of the program, Dr. Rohit Kumar Vasa. Dr. Vasa is an attending neonatologist at the Ann and Robert Lurie Children's Hospital of Chicago Northwestern University, a neonatology site leader and chairman, Department of Pediatrics, Mercy Hospital and Medical Center, Chicago, Illinois. Enjoy the presentations. Dr. Vasa.
Thank you. And let's go along with the program this evening. But before I start anything, I don't know if everybody knows that June 1 through June 7 is a National CPR and AED Awareness Week. Now, I don't know if we planned this intently or it just happened this way, but it's a good coincidence that we are presenting this resuscitation seminar during the CPR Awareness Week. So welcome everybody. I welcome the participants from US as well as participants from other countries, including India. And for this evening, we have three eminent speakers. If I go into the details of their bios, I would spend the rest of the evening just describing their achievements. So instead of that, what I will do is I will mention their titles and their presentations will speak for their expertise. I will also echo the housekeeping issues that Dr. Murthy mentioned, especially using the chat only for questions. And please use the mute settings on Zoom or cell phone, whatever you are using, so that there is no extra disturbance. And we'll try to handle as many questions as we can for the evening. So let's move on with our first speaker, who is Dr. Terry Vandenhoek. He's going to speak on the adult resuscitation updates. And he is a professor and head of the Department of Emergency Medicine at University of Illinois at Chicago. He's a professor of physiology, biophysics. He is also a director program for emergency cardiovascular care centers for cardiovascular research and Global Health University of Illinois at Chicago. He is also a Chief Medical Officer of UI Health. So I welcome Dr. Terry Vandenhoek, and floor is yours.
Thank you so much. Can everyone see this? So the Resuscitation Updates 2020, I want to thank you for the opportunity to speak to this group. And I've been at UIC for over 10 years, and I've been fortunate enough to serve as Chief Medical Officer as well for the last couple years, as well as direct the Department of Emergency Medicine. We serve a very diverse population, and a population that is affected by many risk factors that affect COVID outcome, including hypertension, diabetes, BMI, lung disease, asthma. And so we have become very familiar with rapid decompensation in the era of COVID, and have had to deal with that in terms of both the out-of-hospital setting and working with EMS, as well as the in-hospital setting. So I'd like to just walk through some of the updates. I think that you cannot talk about updates related to COVID without at least going back to the basics of CPR, and remembering that already back in 2015, there was a renewed emphasis on decreasing the amount of hands-off time, that we realized that our outcomes were very much related to how much time we were spending compressing the chest, not overventilating. So back then already for the adult, we went to 30 to 2 compression to ventilation. We try to minimize our pauses for breathing pulse checks to less than 10 seconds. We wanted to make sure that we ensured adequate compressions and allow for full recoil. And avoiding excessive ventilation is critical. We also have to remember that in the context of, as we go forward in some of these updated guidelines, we continue to focus on quality CPR. We have done that in our own institution, even as we're working on our cohorted COVID units. We're looking at monitoring our depth of compressions and rate, and minimizing interruptions, and looking at how long it takes us to defibrillate. And of course, one of the key indicators that we look at are compression fraction, trying to get over 60%, if not 80%. And we are continuing to do code debriefings, as many of you have done at your own institutions. But it's really interesting to look at some of these numbers in the era of COVID and realize that there are delays as a result of some of the additional factors that come into play. So I think many of you are aware of this interim guidance for life support for COVID-19. I think it's a really good document to review and look at carefully. There's a few things that are emphasized in this, which is donning PPE before entering the room and the scene, and not to rush things. It's really critical that we reduce provider exposure. We, in some of our cohorted COVID units, have used PPE champions to monitor how people are doing with this. They limit the number of personnel that can go into the room. I think that Vinay will be talking about this later in his talk, to consider mechanical CPR devices who meet criteria. And absolutely, in terms of handoffs, communicating the COVID-19 status to any new providers that are taking care of the patient. One thing that I do before I go into my emergency department shifts is I like to review personal protective equipment. There are certainly different videos out there, but just one that I wanted to highlight that that I have looked at a fair number of times is actually publicly available in the New England Journal of Medicine. It's just about 8 minutes, and it's really critical if you're going to respond to a cardiac arrest that you be very comfortable with putting this equipment on and donning and doffing appropriately. to protect yourself, and also to watch others as they do it and remind them that how to do it correctly. So some of the strategies that are highlighted in the guidance for adults is the use of a viral filter, a HEPA filter for ventilation. We do that for all of our patients. We used a cuff tube. We also have established airway teams at our hospital. That's one of the things that has been very, very successful in terms of making sure that we increase our first pass success so that we don't have to have multiple tries at an airway. We pause chest compressions to intubate so that there's not a movement, and that increases the odds of successful intubation. We use video laryngoscopy. One of the things that is critical is thinking ahead. And when we first started in taking care of COVID patients, one of the things that we realized is that there were significant differences in how long some providers would take care of cardiac arrest patients, how long they would stay on the chest. We would have 40-minute resuscitation attempts on patients that had a very, very low likelihood of a successful outcome with low end-tidal CO2s. And those are things that we have really tried to think ahead of in terms of, as a team, what types of patients are we going to continue to do more prolonged CPR, just to minimize the overall risk to the providers. And that goes for the in-hospital providers as well as EMS agencies. So in some of the algorithms, and I think Dr. Nadkarni is going to highlight some of this too in his presentation, you can see that this looks very much like a standard BLS algorithm. But if you look at the areas that are bolded and underlined, there are some new additions to this, which include donning PPE and limit the number of personnel. I cannot emphasize enough the importance of being comfortable with PPE, being comfortable with putting it on. I've seen some very prolonged responses with people who did not know how to put on their PPE, and as a result, the response to the code was delayed by 10 minutes or more. And so we work really hard to, if you're on a code team, you need to be familiar with PPE. The other things that you can see is that using a bag mask device with a filter and a tight seal are critical aspects of resuscitation. And again, it's helpful to become familiar with this equipment ahead of time so that you know the proper use and minimize the risk of exposure. And then again, with bag valve mask devices, you can use the filter and a tight seal. The other option is to use continuous compressions with just a passive oxygenation using the face mask, and you can actually put a mask over that. That's something we've done as well, and that can be a good option. And then when the AED arrives, it's the standard process as before with 2-minute cycles. For lay rescuers, what's interesting is that we've noticed this as we've monitored cardiac arrests in the state of Illinois. As we've done the shelter in place, there's been a large shift actually from cardiac arrests that occur in a public setting to cardiac arrests that occur at home. And when you really think about it, the lay rescue that is in the home is someone that's probably already been exposed to COVID. And so in the guidance, I mean, it highlights the likelihood that the lay rescuer has already been exposed to COVID, that is probably, if they are willing and able, that they should be able to do hands-only CPR. There are some precautions that could be taken if it's practical to cover your own mouth and nose with a face mask or cloth, and to cover the person's mouth and nose with a face mask or cloth. But again, realizing that in the home where most of these arrests are occurring, the lay rescue or responder is likely to have been exposed to this patient already. For ACLS, again, you'll see in the yellow areas the donning of PPE and limit the number of personnel. Again, consider resuscitation appropriateness and really know what you're going to do before you do it in terms of the types of patients that you're going to do a prolonged resuscitation. Prioritizing the intubation and resuming CPR, again, to increase the likelihood of a success, to pause chest compressions for intubation, and then consider a supraglottic airway or bag valve mask device, but use a filter and a tight seal. And it's critical that you use the viral filter. And then the rest of the algorithm looks very much like your standard ACLS protocol. And this is just a reminder to prioritize ventilation strategies. It's one of the critical aspects, and so you know, this guidance goes through a fair amount of detail as to how to do that. Then the final thing I wanted to say is that so we have been monitoring cardiac arrest in the state of Illinois for several years now at this point. We are very proud of what has happened in partnership with over 85 hospitals and EMS agencies throughout the state. We worked hard to almost triple the rate of bystander CPR in hotspot neighborhoods. And these are neighborhoods that have a high incidence of cardiac arrest and very low rates of bystander CPR. And we've gone into schools and churches and communities to increase bystander CPR rates. One of the things that we've noticed during this time is that our cardiac arrest incidence has increased almost 50% during COVID. And that goes along with a decrease in patients who present for STEMI. Certainly some of these arrests are related to COVID, but we also believe that many people are staying at home for too long, are scared to come in to the hospital when they need help and are not calling for help. And so part of our engagement strategy is now also trying to prevent cardiac arrest by going into communities, reminding them of signs and symptoms of heart attack and not to wait too long before there's a cardiac arrest. And so one of our concerns right now as we go through this era of COVID is that there's a new health disparity that is there, not only with COVID, but with patients waiting too long for STEMI care. So I want to thank you for the opportunity to speak tonight, and look forward to questions later.
Thank you, Dr. Terry. We will have the question answer session at the end. I already received some questions for you, so we will do that at the end of all three presentations. Before I move into the next presentation, Dr. Suresh Reddy, who is the president of API, is here, and I would like him to address the audience. Dr. Reddy.
Thank you, Dr. Vasa, and thank you all the speakers and especially the audience for joining today. Thank you for the program director, Dr. Vemuri Murthy, for creating this program. Thank you again, and hope you enjoy the talks. We have wonderful speakers today. Thank you for joining. Over to you, Dr. Vasa.
Thank you. Thank you for your comments, Dr. Reddy. And let's move on to the next presentation. And the next speaker is Dr. Vinay Nadkarni. He is a professor of anesthesiology, critical care, and pediatrics at the University of Pennsylvania, Perelman School of Medicine. He is also a past chair of the American Heart Association International Committee, and he is also a past chair of the ILCOR, which stands for International Liaison Committee on Resuscitation. His assignment for this evening is neonatal and pediatric resuscitation updates. So the floor is yours, Dr. Nadkarni.
Well, thank you, Dr. Vasa. Dr. Reddy, Dr. Murthy, and I will follow now what Terry has really laid out for us and try to emphasize not only some of the changes with the COVID pandemic that have occurred, but a little bit about how we are trying to implement or transition to practice the guidelines that have been made. Let me just try to, give me 1 second. It was not advancing, so I'll move to this. The basic principles that Terry was mentioning are to balance the immediate needs of the victims with the healthcare providers' safety or the first responders' safety. We have to balance the current available resources with the anticipated future resources needed both in PPE and personnel, and we have to balance the rationing of scarce resources while using those resources to salvage the most likely to benefit. As Terry mentioned, for out-of-hospital cardiac arrest with social distancing, there's a much higher likelihood of sudden cardiac arrest in the home or among family members and close contacts who are already in contact with the victim. But what I'll point out to you is that for infants and children, rather than advocating hands-only CPR, the American Heart Association and ILCOR advocate for the combination of chest compressions and rescue breathing, especially for those who are already in close contact or family members. What differs then from the standard guidelines? The time it takes to put on appropriate PPE. Efforts to limit the number of team members, crowd control, and working behind a closed door rather than inviting everybody in the area to participate. A focus on minimizing aerosol generating procedures. The use of HEPA filters for all airway maneuvers. Intubating early with a cuffed tracheal tube. And connecting as early as possible to closed circuit mechanical ventilators to avoid aerosol generation. The intubator and the technique is advocated to be those that have the highest chance of first pass success. And in the question and answer session, I'd like to ask Terry if he has taken any special policy, procedure, or changed any of the Code Blue policies that facilitate limiting the number of people in the room and facilitating the person with the highest chance of first pass success for airway intubation to be at the head of the bed. One important change, Terry mentioned that since 2015, the strong emphasis on avoiding interruptions of chest compressions. But during this COVID era, because of the risk of aerosol generation, the American Heart Association and ILCOR suggest that we pause chest compressions during the intubation procedure. And we emphasize the tight mask seal, even if it takes 2 people to achieve that tight mask seal. And if intubation is delayed, consider a supraglottic airway with a tight seal. At the end of my presentation, Dr. Chakra Rao and the Indian Resuscitation Council have recently published recommendations for India on COVID-19. And one of the things that you'll see in the American Heart Association guidelines really emphasized is this sealing of the mask or the supraglottic airway. What also differs from the standard guidelines previously issued? If the patient is intubated at the time of arrest, consider leaving that patient on the mechanical ventilator, not removing them to provide manual ventilation. Consider the use of mechanical CPR devices for adults and adolescents who meet the height and weight criteria and fit the mechanical device that is available. Note that oftentimes mechanical devices require proper training to effectively use them and avoid unnecessary interruptions of high quality CPR. So if they're being used, they should be trained. An interesting aspect is in patients who have ARDS or COVID infection and are already being managed in a prone position, consider prone CPR. One should consider the risks and also the benefits of flipping that patient into the supine position. You'll see there's a slight difference between the advocacy of prone CPR between the Indian Resuscitation Council, American Heart Association, and European Resuscitation Council guidelines. There really is insufficient data to support or deny extracorporeal cardiopulmonary resuscitation, eCPR, for COVID-19 patients. And this is generally being made and advocated on a case-by-case, patient-by-patient basis. Terry pointed out the key elements that have been emphasized or changed in the adult basic life support algorithm for healthcare providers. Donning PPE, limiting personnel, using a bag mask device with a filter and a tight seal, and choosing to deliver either continuous chest compressions with passive oxygenation using a face mask, or using a bag mask device with filter and a very tight seal. When we look at the pediatric algorithm, it's very similar for donning PPE, limiting personnel, and using the bag mask with a tight seal and a filter. But for children, the 30-to-2 chest compression to breath ratio, or 15-to-2 with 2 rescuers, still advocates using bag mask devices or focusing on assisted ventilation in addition to chest compressions as particularly important in children and in infants. In adults, he highlighted the ACLS protocol, where donning PPE, limiting personnel, and early consideration of resuscitation appropriateness, prioritizing early intubation, pausing the chest compression for intubation, and if intubation delayed, considering a supraglottic airway or bag mask device with tight seal, and attaching to a ventilator, considering a mechanical compression device, and minimizing the closed circuit disconnection using an intubator with the highest likelihood of first pass success. What you will note is that in the American Heart Association algorithms, the medications recommended for adult ACLS and pediatric advanced life support are exactly the same as in the pre-COVID era. In the Indian resuscitation guidelines that I'll share with you at the end, they have also added the consideration of magnesium for use in those patients receiving hydroxychloroquine and azithromycin. In pediatric advanced life support, we continue to emphasize the use of ventilation in addition to compression. We advocate for cuffed rather than uncuffed tracheal tubes. And again, just like the adults, pausing chest compressions for intubation, considering a supraglottic airway device, and connecting to the ventilator as early and disconnecting as infrequently as possible. I will mention mechanical CPR device, not advocating any specific device, but the consideration that the quality of CPR, the limitation of the number of people that are required to deliver sustained or prolonged CPR, and the consistency of delivery is a plus of the mechanical devices. However, the experience and the ability to place and use them and adjust them requires training. And so any mechanical CPR that might be used should be coupled with training. I just want to flash for you the recent, on behalf of Dr. Chakra Rao, who I believe is on the call, just to mention that the Indian Resuscitation Council has come forward with their comprehensive cardiopulmonary life support for the COVID patient, which really, again, emphasizes donning PPE and starting with cycles of 30 compressions and 2 breaths. One minor difference of the Indian guidelines from the American Heart Association, European, and ILCOR guidelines is that they state a chest compression rate of 120 beats per minute, while the other organizations generally recommend 100 to 120 per minute. And you'll notice here circled that if the patient is already on a ventilator and supine, prone, they advocate to turn the patient supine rather than delivering prone CPR. These are very minor considerations. And of course, many of the COVID patients who are already intubated will have the etiology of their arrest as an airway event, lying prone, many secretions. Our experience has been that sometimes either the obstruction or the dislodgement of the tracheal tube can be an etiology of arrest for prone patients and should be addressed early. ILCOR, under Keith Cooper and Gavin Perkins, did an extensive evidence-based review of aspects of care for COVID patients in cardiac arrest, and were only able to uncover very low level of evidence and recommendations that represent very low certainty of that evidence. The 5 key caveats are that chest compressions and cardiopulmonary resuscitation do have the potential to generate aerosols. Lay rescuers should thus consider chest compressions only for adults and public access defibrillation. Lay rescuers who are willing, trained, and able should consider providing rescue breaths to infants and children in addition to chest compressions. This is the key difference for infants and children. Healthcare professionals should, of course, use personal protective equipment to avoid aerosol generation and transmission. And it is reasonable for healthcare providers to consider defibrillation before donning personal protective equipment in situations where the provider assesses the benefits may exceed the risks. Again, the balance of care for the victim versus protection for the healthcare provider. Finally, again, back to the Indian Resuscitation Council guidelines, the emphasis, as in all councils, on the consideration of rapid sequence intubation so that you don't ventilate before placing the tube, if possible, and potentially using adjuncts like video laryngoscopy so that the person intubating does not have to put their face in close contact with the aerosols that are being generated from the mouth of the victim. And again, mentioning the consideration of antiarrhythmics if the patient is on potentially arrhythmogenic medication. The Indian Resuscitation Council also addresses post-resuscitation care. If you read their guidelines carefully, they suggest limiting the duration of resuscitation efforts to no longer than 20 minutes and no longer than 10 minutes if an end-tidal CO2 above 10 is not achieved. And they also provide suggestions for handling the dead body if resuscitation is not successful. The American Heart Association and ILCOR did not identify any specific time frame for which resuscitation efforts should be stopped. All of this information is available on the CoStar website, ilcor.org. And I will point out that for more extensive guidance in India for children with COVID infection, the management in the pediatric intensive care has been summarized and recommended in the Indian Journal of Pediatrics and published on March 29th in 2 parts. I think I will then pause and request Dr. Rohit Basa to perhaps make some specific comments about the newborn and babies and their resuscitation. Thank you.
Thank you, Dr. Nadkarni. About the mother newborn dyads, when all this problem started in February and March, there were a lot of controversies, mainly because different organizations had different guidelines. For example, WHO had little more liberal guidelines in terms of breastfeeding, skin-to-skin care, etc. Whereas CDC and other organizations, American Academy of Pediatrics, they were little more restrictive and insisted on separation at the time of birth. And the main reason for that was that we do not know how the infection can be transmitted, whether it is transmitted in utero or is it transmitted at the time of delivery. So in order to protect the baby, most of the recommendations were based on separation at the time of birth between the mother and the baby. In terms of resuscitation, the questions that come up about PPE, even though most of the controversies are starting to resolve now, but in the earlier days, the questions were, should every laboring woman be tested for COVID-19? Should PPE be worn at every delivery? If the mother is tested, should there be only one test or more than one test? Now, in the states where the incidence was much higher, like New York, it was very clear they were very much in favor of testing every woman. But in the states where the incidence was very low, they were not that firm. But most places have now been doing PPE at every delivery. In terms of limiting the personnel, which has come up in previous 2 presentations, neonatologists practice the same. So most COVID positive or PUI deliveries, the attendance would be by an experienced neonatologist and an experienced nurse. The reason for experienced neonatologist is so that there are not that many attempts made at intubation if it is necessary, and more personnel can always be called upon if needed. So only 2 attendees, a physician and a nurse at the delivery. The initial steps don't really change too much, except the issue of suction. Since suction is an aerosol generating activity, the suction should be limited unless it is causing obstruction somewhere. And even in the previous NRP versions, people have been placing less and less emphasis on suction, including suction in case of meconium-stained amniotic fluid. The other issue comes about in terms of controversy is intubation. In the adult world, there is more emphasis on intubating because then the chances of aerosolization are much less. However, such conviction is not seen in the neonatal world, probably because we don't use the cuffed endotracheal tubes and we use the uncuffed endotracheal tubes. So even with intubation, there is a chance that there will be aerosol generations. We would also restrict the endotracheal medications to probably surfactant only and no other medications, because any medications that are used can generate aerosols. So any medications that are needed should be preferably be given by intravenous route and not through endotracheal tube. And previous versions of NRP have also stressed that medications are preferably given through the IV route. In terms of babies who need transfer to NICU, one process that many people have recommended is that the team that attends the baby at the time of delivery should hand over the baby to another team who is ready outside the delivery room and take the baby to NICU so that there is no cross-contamination. Of course, this requires more personnel, more use PPEs, etc. But it is safer for the baby to be transferred by two different teams rather than the same team. I think these are the controversial and specific issues that pertain to the neonates. And certainly, if there are any questions, we can discuss during the question answer session. Did you have anything more to add, Dr. Nadkarni? I think Dr. Nadkarni is muted.
Great. Now I can talk. No, you covered everything. You covered everything great.
Good. Thank you. And we can have more discussion during the question answer sessions. So let's move on to the third presentation, and the speaker for the third presentation is Dr. Amit Sharma, whose topic is challenges of diagnosis and management of cardiac emergencies. Dr. Sharma is an interventional cardiologist who is also a regional dean for the Burrell College of Medicine and chairman of cardiology at the Rockledge Regional Medical Center, Rockledge, Florida. Floor is yours, Dr. Sharma.
Thank you, Dr. Yasa. So let's see if I can. All right, good evening, everyone. Can you all see my screen here?
Yes.
Okay. Well, first of all, thanks to Dr. Vasa, Dr. Murthy, and Dr. Suresh Reddy in organizing this very important webinar and a very timely one. And thanks for including me to speak on a topic which is in front of you. So since Vinay and Terry has done a great job and have summarized the key guidelines, I thought I would use a case-based approach. So I'm gonna actually go over 4 cases briefly, and these are really very practical cases that you may actually come across when you're taking care of your COVID patients. So very, very practical approach, a few slides, but towards the end, please, let's have a discussion and ask me questions, whatever you may have. So how did I pick the cases? So I picked the cases that would really make a change, modify your practice while you're taking care of these COVID patients. And it would actually, if you're a teacher, then it would actually have some teaching points which you can pass it on to your mentees. And these are real cases. Some of my colleagues from Louisiana and New York contributed to them. I modified some of these cases to illustrate the teaching points. So the question, I often get asked is, well, why should a cardiologist be so excited about COVID? Well, the reason is in front of you. It turns out the disproportionate number of patients being affected by COVID, they are the patients with heart disease. You see up there, this is the recent article by Dr. Mehra from Boston and published in NEJM recently. And you see there, the patients with coronary artery disease, their risk of mortality is actually at least double of the patients with non-coronary artery disease patients. Congestive heart failure, it's even worse. It's at least 4-fold increase in mortality if your patients have congestive heart failure, that they're at risk for dying from COVID. And cardiac arrhythmia is also there. So please recognize that cardiovascular disease is probably the most robust risk factor for mortality and morbidity for these patients. This is a busy slide, but this summarizes how this virus can affect heart. So on the top portion, what you see is a typical viral syndrome that we encounter with a lot of bacteria and a lot of virus. This is systemic inflammatory response syndrome. You're very familiar with this. This is classic sepsis, SARS, syndrome that would actually cause multi-organ failure, including, heart being involved. But we also know that this virus directly affects the myocardium, causing myocarditis, and we're going to see a few cases. So again, recognize that this virus does affect the heart directly, apart from heart being involved in the systemic inflammatory response syndrome. So if your patient's heart is affected and they have COVID, that's a bad news. And you see up there, if you have a myocardial injury, which is extremely common, so this is a conservative estimate, 40% of all COVID patients. This also includes younger individuals. So young patients, we are seeing a fair amount of myocardial involvement. And one thing that, we all maybe overuse is troponin, which I think is okay in this scenario. If you see elevation in troponin, that is not the simple troponin leak that you ignore and move on. That really means something. And what it means is you can see that the survival actually goes down, whether they have coronary artery disease or not, whether they have congestive heart failure or not. Elevation in troponin in general predicts poor outcomes. So if you're checking troponin, pay attention and be worried about the patient. So moving on to our first case. So this is a 67-year-old female. She had history of ischemic heart disease. She had PCI done a few years ago and has one stent in one of the arteries. She has been very, very stable. She has hypertension and obesity, as most of our patients have in South here in Florida. And she presents with really mild COVID syndrome. So she was on the medicine ward, and this was actually early experience with COVID. So it was taking us 3 days to get our test back. So she was really okay on the ward. And fourth day, the test came back and she was really not dependent on oxygen. So she was discharged. However, on day 10th of her initial presentation, she returns back now with sudden worsening of shortness of breath. So this is a brief exam. So she is tachypnic. She has increased work of breathing. She is in shock. She's tachypnic. Respiratory rate is much higher than 25 actually. And she does have the stuttering troponin. So it's not like, troponin in thousands, but she had a fair amount of, this is highly sensitive troponin, the normal being less than 0.04. So she did have mild elevation of troponin. I would say that the pattern of the troponin was flat. Her D dimer is elevated at this second presentation, and D dimer was elevated actually at her initial presentation as well. And as you know, the D dimer elevation is actually common in these patients, and D dimer is also a predictor of poor outcomes in these patients with COVID. So this is her chest X-ray, and this is her CT scan. So pretty classic, rather classic CT scan and chest X-ray of moderate COVID patient. And, but it was present even on her day 1 of admission. So this is actually day 9th. So not much has changed. So what was changed was her baseline EKG. And I want to make a teaching point here. So if you look at her EKG a week ago, that is on the right side, the colored image. And really, it was normal sinus rhythm. Her QTC was borderline prolonged when she was discharged. And now she has come with sinus tachycardia, and she has developed this right bundle branch block. What you also see is T-wave inversion in lead V1 to V3. I don't know if I can use the cursor here, but I'll let you actually look at the EKG, because there's a teaching point that you could possibly use tomorrow if you were to see a possible COVID return. So the options for you guys to think about is, what should you do next? So this patient was treated for COVID, got better, and now she's back on day 9th or day 10th, and she's more short of breath, she's near shock, and her EKG has changed. So the cardiology team was consulted because of, not for shock, because of not for her respiratory distress, but like we are always consulted for is elevated troponin, which is okay. But the EKG was a pattern that suggested us something, and I'll tell you what we did. But the options here was, activate the cath lab. She has a stent and her troponin is elevated, something to think about. Intubate and increase the PEEP because she's tachypnic. She was hypoxic in 90s, with I would say about 4 liters via nasal cannula. Do a bedside echo or continue supportive treatment of COVID and call it, her COVID has worsened. And there were a lot of media and a lot of things were going on actually about a month and a half ago, and this was really actually reported a lot that these patients, they get better for first 1 week, and then 10th or 12th day they actually get worsened, which is true. But we decided not to continue the supportive treatment of COVID. And I know Dr. Nanda, who has been mentor for almost all the cardiologists in the nation. They have, Dr. Nanda has taught all of us the echocardiography. So we actually picked echo, and her echo was rather very classic for what we call the McConnell sign. And this is, this is suggestive of acute pulmonary embolus. So this lady's, this is the right ventricle on the left. And as you can see that her RV free wall is dilated and hypokinetic, and her RV apex was hyperkinetic. And this suggested possibility of acute pulmonary embolus. And she was not stable enough for us to actually do a contrasted CT. So we actually did a bedside lower extremity Doppler. Indeed, she had bilateral lower extremity DVT. So what did we do? How did we treat this fairly young individual? She was hypoxic, she was in shock, and she was in RV failure. So we decided to actually give her systemic thrombolysis in our ICU. And upon discharge, she was on an oral anticoagulant, and she made actually good recovery. She was discharged on day 5th of this hospitalization, and has continued to actually done very well. So the take-home point, I want to mention for this case is that realize that all shortness of breath is not due to COVID. COVID is a diagnosis, which I think making rounds on the wards, I think it's overused. So when people are not sure, they say, oh, I think it's COVID, we're gonna wait 3 days. No, I think you got to keep your differential, very broad, and recognize that pulmonary embolus is a very common presentation and a common occurrence in these patients with COVID. 30% is a really very conservative estimate. So some case reports from Spain and Italy, they're coming up now, And this incidence could be very high, could be as high as 55, 60%. But I think 30% is a reasonable estimate that these patients, when they suffer from COVID and when they're hospitalized, and these are also mild COVID cases who are on your medical wards, they will actually develop pulmonary embolus. So keep an eye, because that is very easy to treat. Now, I still don't know how to treat COVID. I don't know if hydroxychloroquine works or not, but I do know how to treat pulmonary embolus. So that is a low-hanging fruit. Recognize pulmonary embolus and treat it really, effectively and aggressively, I would say. Then again, I think if there are any medical students or fellows, one point again, basic to internal medicine is, or our basic training in medical school is pay attention to history. So this lady, when we actually talked to her, she said, I was fine. And then all of a sudden, I actually started getting very short of breath. So, while COVID can do that, but such a sudden onset of shortness of breath really was a red flag that we said, well, that probably makes little sense that why one afternoon should be so short of breath. Also, try to compare EKGs if you have a baseline EKG, and know that although these patterns are not specific, certainly not diagnostic of pulmonary embolus, but this is a very cheap tool to at least suspect a pulmonary embolus type pathophysiology in these patients. So a new right middle branch block and a T-wave inversion in lead V1 and V3 is frequently seen in patients when they develop acute PE. And use bedside echo when you can, and I think it's certainly is available to most of us in pretty much all the healthcare centers. It's very non-invasive and will actually help you, and certainly help in this case. The other really teaching point I want to make, with this case is that we are actually using a lot of non-contrasted CT, which is great, I think, but know that, like in this case, non-contrasted CT, and you all know this, but I can emphasize it again, will not be helpful in, detecting pulmonary embolus. So if you have pulmonary embolus on your differential, and if possible, if the renal function and what have you will allow you, consider doing CT with contrast and keep pulmonary embolus upon, on your differential. The other really very important point is these patients, they are leaving our hospitals early. Nobody wants to stay in the hospital, rightfully so. We are discharging these patients. They are not recovered to normal. They're dyspneic. They have limited mobility. They go home and they are certainly nobody's socializing, nobody's going out. They're really homebound. They are actually developing venous thromboembolism much more than what we have seen before, just because our society has changed. People are homebound, and we are creating actually a really nice milieu for DVT and pulmonary embolus to develop in these patients. So when you discharge these patients, you probably should consider discharging them on some sort of, are there low molecular weight heparin, or there are actually oral anticoagulants available now that you should consider discharging these patients, let's say for like 2 weeks or 30 days. And that's actually guideline supported. So please consider venous thromboembolism prophylaxis when you discharge these patients from your wards, because indeed, they may not die of COVID, but they will die of a venous thromboembolism incidence. All right, so next, a very practical case, and you may, I hope you never see it, but you may see it with this COVID epidemic, reported from all over. So this is a patient who presented with chest pain and ST elevation. So this is a 66-year-old female, really previously healthy, did not have any medical problems. In fact, did not take any prescription medications. And she'd been having the stuttering chest pain for about 24 hours or so. And we inquired, and she was not dyspneic. So on exam, she was anxious and diaphoretic and looked really toxic and sick. Her systolic blood pressure when she arrived in the emergency room was kind of low normal. She was normal so tachycardic, mildly tachycardic, I would say. Her exam had mitral regurgitation in the exam, and she had crackles. So she had clinical stigmata to suggest acute heart failure. And her key labs were, her D-dimer was significantly elevated, and her troponin was fairly elevated as well. So again, 66-year-old female, the only complaint she had was chest pain. And indeed, I think it was not a classic angina because she had it for a day. But, in this COVID era, I think it's just history is important, although it was not a classic angina, but a chest pain, no dyspnea, a little toxic looking female. And this was her EKG. I'll let you look at it. So basically what you see here is there's a diffuse ST elevation and there is PR depression. And, rightfully so, many of you would say, yeah, this is pericarditis. So certainly, this was pericarditis, but the lady actually looked toxic and sick. So we decided to take her to cath lab. And as you would expect, her coronary arteries were really nice and normal. But, we said, well, while we were doing the heart cath, she dropped her pressure even further. Her blood pressure dropped to like 80s, and she actually was cold and diaphoretic, so she was clinically in shock. And we, at the same setting, we did a right heart cath. We left a swan, and that confirmed cardiogenic shock. As you can see, her cardiac index was fairly low. So this is a lady who presented with only complaint of chest pain with shock. And she got fairly sick, while we were finishing up the heart cath. And so we actually had to use Impella. This is left ventricular assist device, which can be helpful in management of shock. You would start on pressor like dobutamine, we did. And the very night, she presented, she tested positive for COVID. So this was actually COVID myocarditis. This was COVID myocarditis. And when we started on dobutamine about 12 hours to early morning, she had a EKG, which is in front of you. Her QTC has prolonged, and she actually started having polymorphic VT or Torsade type morphology. So the reason she went into Torsade is multifactorial, but all our patients who are in ICU, or many of our patients, we were giving them hydroxychloroquine and azithromycin combination. So this is actually a recent JAMA article. And what you see here is that indeed, if you use these drugs, they will actually predispose these patients to arrhythmia, and indeed, QTC will be significantly prolonged if you have patients on hydroxychloroquine, and worse if they are on hydroxychloroquine and azithromycin. So certainly keep an eye on QTC prolongation. So this patient had to be temporarily paced. So the next day she actually received a temporary pacemaker. And we had to actually interrupt her hydroxychloroquine and azithromycin. This is a nice review actually I've taken it from Lancet. So COVID myocarditis is reported actually from all the COVID hot zones, if you would. And, the left side is the classic CT scan finding. And T-wave inversion is what is illustrated on this EKG here. And prolonged QTC is also a phenomena that you would see with COVID myocarditis. And the picture C is the bedside echocardiogram, and you can see the cavity dilatation and thickening of the myocardium. And the D is a cardiac MRI, which showing late gadolinium enhancement. So this was from actually Lancet, so pretty similar to the case I presented. So with supportive care, we supported her with the LVAD or the Impella, you can actually consider using the balloon pump if Impella is not available at your institution. And, I would really strongly suggest that these patients, they can get very, very sick. So you please involve a transplant team. If you don't have it at your hospital, then there's usually a transplant center. And they really actually guide you very well in how you actually manage these patients with myocarditis. Some of them, they actually require high dose steroids and a bunch of things, that, these patients may need. So consider involving your transplant center on guidance on how to manage these sick patients with COVID myocarditis. All right, so take home points from this case. So recognize that chest pain as the only complaint of COVID is possible. So these patients, they may not have dyspnea up front. All they would present is like pleuritic type chest pain, and that could be their only complaint. It's possible. It's a very fascinating disease, a very mysterious disease. We're still learning, but don't dismiss a pericarditis type chest pain. Consider, especially these days, if you see a patient with pericarditis, consider COVID on your differential. Look for the pericarditis type pattern on EKG. Consider right heart cath early, and really early and aggressive treatment of shock is the key. And consult transplant team, watch for QT. And when you actually take care of these patients, and the previous speakers have done a great job of outlining it, know how to use PPEs and protect yourself. All right, so case 3.
You have 5 more minutes.
Okay, I think we should be in time. So this is a 62-year-old patient, hypertension, diabetes, been having chest discomfort for 24 hours and progressive dyspnea. He did not want to come to the hospital because of fear of catching COVID. So day 2, symptoms got worsened. He started looking toxic and sick. So family called EMS and he arrived. He was in shock as well. He had clinical features suggestive of acute heart failure as well, as you can see here. And this was his EKG, So as you all can see here, there's a significant ST elevation concerning for proximal LAD, infarction or ischemia, and there is actually a developing infarct. So this was a late presentation of anterior STEMI, which, unfortunately we are seeing a lot. So as you can see here, many of you may not have, be familiar with the angiogram, but on the left side is the pre-cardiac cath, and you can see there's a small nub. That's where this big artery LAD is hiding. And we certainly were successful very quickly in opening that up. Very nice results. But he actually presented late, so he had infarcted quite a bit of myocardium. So although the interventional cardiologist, we feel very happy when we open the artery, and it looks very nice, but he has infarcted quite a bit of his myocardium. He was very sick again, needed the left ventricular assist device. He actually is in hospital and doing well, so he's not in ICU. His Impella has been weaned off and done fairly well, but got very sick. So the point here is that COVID phobia is very much prevalent. It's hard to believe that we have seen about 40% decline in STEMI. So patients, unfortunately, are dying at home, or patients who are coming to us, they are presenting late. So please educate your patients about taking the angina and chest pain seriously, and they're probably okay coming to the hospital. The risk of catching COVID is certainly there, but the risk of dying of run-of-the-mill acute MI is much higher. So this is a short case. I think I've been asked a lot by all my patients. There've been a lot of media about, ACE inhibitor and ARB, are they safe? And you probably have a lot of patients ask you about, well, should I stop my lisinopril or should I stop my losartan? So recognize that COVID uses this ACE inhibitor machinery to get into your body, if you would. So the concerns initially we had was, well, if you have upregulation of ACE inhibitor, could this affect your possibility of catching COVID more than the patients who are not on ACE or ARB? And turns out, so far, all the studies are looking very, very promising that, indeed ACE or ARB does not increase your risk of catching COVID. Maybe ACE inhibitor may have some protective value. So please counsel your patients, have them continue their ACE and ARB if they're on it. These are important medications. We do not want them to be discontinued. All right, so this is the last slide. So in conclusion, recognize that COVID can present with a variety of cardiovascular syndrome. Know that cardiovascular disease is probably one of the strongest predictor of COVID mortality and morbidity. Know that dyspnea and COVID is not only from COVID, it could be from other causes. Learn and manage the shock aggressively, which we all know. So these COVID patients should not be neglected. I think if you're aggressive, you can bring these COVID patients back to life and make a successful discharge. And COVID phobia has certainly increased the morbidity and mortality. So please educate the patients not to ignore these symptoms. ACE and ARBs are really okay, no reason to change. And multidisciplinary team approaches is the key. This disease has taught us really to work with, as a team. This is, a good disease process that have really re-emphasized the teamwork in medicine. I'm going to stop here and I will hand over back to Dr. Yasa.
Thank you. Thank you very much for your presentation. And let's go to question and answer session. Every presentation was excellent, as I see from the comments received from the audience. And there is a question for Dr. Sharma. Do you have any comments about risk of chloroquine? Are you seeing arrhythmia in these patients? Dr. Sharma?
Yeah, so, that's a great question. So I do, and I showed you the slide. It's a nice, review. And certainly, if your patients are on hydroxychloroquine and if you add azithromycin, the QTC will be prolonged. These patients will be at high risk for arrhythmias. If there's a strong lobby of infectious disease physician, they feel that, these drugs work, maybe they do, but, monitor their EKG closely, number one. Number two is make sure they're not on any other drugs that would actually cause further prolongation of QTC. So if you add hydroxychloroquine, azithromycin, and I've seen like some people using, levofloxacin or ciprofloxacin along with it, I think that would be a really recipe for arrhythmia. So avoid other drugs that your patient could be. And then the baseline risk, if you have a younger patient, they have normal QTC to start with. I mean, you probably can use these drugs. I think a lot of patients are on these drugs. Chloroquine is, as you know, hydroxychloroquine is frequently used for long-term use. But if you have an older individual with history of arrhythmia, with history of coronary artery disease or heart failure, you would consider avoiding hydroxychloroquine and azithromycin in those patients.
Thank you, Dr. Sharma. One of the points that you made about not all shortness of breath is COVID. I can cite one of the encounter I had. As a neonatologist, I don't see adult patients, but while I was sitting in the NICU, one of the nurses who was right next to me, all of a sudden started to have shortness of breath and started perspiring and was taken to the emergency room and turned out that she had pulmonary embolism. So
Exactly, so no, I'm glad you mentioned, and that was my case one. And the reason I picked that as a case one, that, that has been a consistent theme. And as pulmonary embolus, 10 years ago, all these patients, they would die in the hospital and the cause of death would be cardiac arrest. And actually 10% of in-hospital mortality, irrespective of the reason of hospitalization, is actually acute PE. So I do suspect, now I don't have the data, but I think a lot of patients, they may not be dying of COVID. They may be dying of a preventable pulmonary embolus, especially with this procoagulant, surge and stage that we have seen with this virus. And, the humble thing about pulmonary embolus or DVT is it's all preventable. So use VTE prevention is a must for any COVID patient.
thank you. There are two questions that are pertaining to the bystander CPR in out-of-hospital cardiac arrest during COVID era. One of the question is, have you noted any change in percentage of those who receive CPR in OHCA? And has the survival from OHCA changed during COVID time? And then the second question in the same reference is, what is the lay rescuer's perception about performing CPR during COVID time? And maybe Terry can handle this.
Yeah, so it's a great question. I mean, I think we're still looking at our data from this past year. We get data from about 85 hospitals in the state of Illinois, and so in the last few months, our sense is that the survival rate has maybe gone down just a little bit, not as much as I would have thought. I think that an interesting feature is that many of these arrests have now gone from in a public space to home, and with the stay at home protocol, when there's a cardiac arrest at home, there's oftentimes another person that's actually in the house. So the bystander CPR rates in those cases tend to be actually higher than what we've seen before. The bystander CPR rates in public settings is actually considerably lower. And so there's they're going in different directions, but the overall survival rate is just a little bit less. The issue is that because the denominator is so much higher, because we're seeing a much higher incidence of cardiac arrest, 50% increase, which is really dramatic. It's consistent with what's been reported in Europe, that the number of people dying due to cardiac arrest has increased significantly. And I don't think it's related directly to COVID as much as it is to, as our prior speakers have pointed out, that there's a decrease in access to care for STEMI.
Thank you. As long as you have the forum, there are two other related questions that you could that were specifically addressed to you. One is, have you modified the number of people activated overhead or on the cell phone for code blue? And the second related question is, have you changed the experience level of persons intubating the trachea during code?
Yeah, so we actually have an airway team now that is mobilized throughout the hospital, including the emergency department, which was actually a pretty controversial thing to do. I think that there's a lot of discussion in emergency medicine as to is this the best way to go. It took a 2-hour faculty meeting for us to walk through it, and I still have my job, so that's great. But everyone was actually thought it was the best approach to have an anesthesiologist and then there's a nurse. And so there are 2 people in that room. The anesthesiologists generally wear a PAPR because of the visualization that they can achieve. The other thing that I think somebody else brought up in the chat it's a little bit harder to communicate as a team when you're wearing PPE. It's just, that's why I've certainly worn a respirator. That's a very difficult thing to use and talk to people. A PAPR is actually very nice generally. When I work my shifts, I wear an N95, a standard 3M N95 with a mask over it. And I talk louder, and I work hard to talk louder, especially in a team situation. For cardiac arrest, first of all, we try to avoid a cardiac arrest on a floor. We actually just took on a resuscitation coordinator that is teaching our nursing staff on the COVID units how to track and trend in terms of a scoring system to look at who may decompensate, and we try to get those patients to an ICU setting before before they need a airway. But if it does happen, we actually have a limitation of people in the room. Try to limit it to 3, if not 4, and certainly not a big crowd. And as Vinay said, you close the door. You don't have an open door policy where anybody can roam into the room.
Thank you. There are 2 questions for Dr. Nadkarni. One is regarding the mechanical device for cardiac compressions. What about the recommendation for CPR in a moving ambulance? Is there any other recommendation than to use mechanical device, different options? I think that's what the person wanted.
Well, Dr. Ramana Rao, I think, is on the call and maybe more qualified than I to make comments on this. But in general, the use of mechanical devices has been most useful in the out-of-hospital ambulance type setting, where it can provide consistently good quality CPR with less risk to the traveling EMS providers. But during the COVID era, I think more hospitals are considering using the mechanical device for similar reasons, to protect the healthcare providers, to try to get less people around the bedside, less people exposed to potential aerosol generating procedures. The risk of going out and buying new devices and implementing them fast, as Terry, who's a CMO of a large organization, is that just having the mechanical device doesn't mean you're going to provide good quality CPR. It has to be trained, practiced, available, cleaned, used, etc. So it's just like high quality CPR. It's something that requires team training and approach, and different roles perhaps early on in the resuscitation than what might be standard for a given code team. So teams that are used to using the mechanical device, that are trained and ready to use, it seems like a very good thing for those that it fits. For young children, they're oftentimes too small. Under the age of 12, they're too small to fit into the device to get the proper depth of compression. Many of Terry's patients have large BMI, are obese, and some of those may be too large to fit efficiently inside and get appropriate chest compression. Terry, do you have any other comments on the mechanical devices?
Yeah, I think that one of the things that you have to be, there's an awareness that if you are taking care of a patient that is higher BMI, that you really have an understanding. Again, this is preparing ahead of time. That if they're not going to fit in the device, please don't try to fit them in the device. And so I think having an awareness of exactly what the BMI is before you even do that is really critical to that situation.
Thank you. There is another question for Dr. Nadkarni. How do you balance between the need to have 2 people sometimes to fix and have a tight seal with the mask versus limiting number of people for code blue? Dr. Martin?
This is a really good question, because on the one hand, we want to protect the people in the room by creating a really good seal, which is sometimes quite difficult to do with a single bag mask rescuer. Maybe a little easier for you in the very small babies, but in the older patients, people with beards, etc., it's more difficult for a single rescuer to maintain a good quality seal and provide the pressures required through bag mask. But the additional person that it takes, perhaps to do two-handed bag mask holding on the face of the victim, while a second person provides the bagging, that potentially means an additional person in the room who needs to be in PPE and additional potential exposure. Because in our hospital, we were fortunate to have plenty of PPE, enough extra providers to train them to do this, we decided to go with the extra person to get the mask. But other situations may be that it is not worth it. I will say that perhaps the most ignored part of the PPE from our staff was the eye protection. People wearing glasses like Dr. Vimari Murthy and myself, we imagined that we were protected by our usual glasses, and they are not adequate. They need to have the goggles or the face shields. And two of our healthcare providers, doctors, contracted, we believe contracted their only exposure was through inadequate eye protection with the rest of the PPE on during a CPR event in a patient who was not known at the time to be COVID positive. So I would just caution that the eye protection is perhaps a very important component of the PPE and perhaps not always considered the highest priority.
I would agree with that. I think that it's a critical part of the PPE protection. And there are some of us that actually really prefer the face shield that goes all the way down around close to the neck. We had one bad cluster that related to inadequate eye protection.
There is one more question, and I believe it would be for me. Should babies born to moms who are PUI or COVID positive be in incubator in the nursery? And is it okay to turn off incubator to avoid this circulation? In terms of the need for the babies to be in the incubator, I think at least for the first couple of days, the AAP recommendation is that babies who are asymptomatic and don't require NICU type of care, they should have testing done at 24 hours and 48 hours. And until those tests are negative, they probably are better off staying in an incubator in the nursery. And the second part of the question is it okay to turn off incubator to avoid circulation? That's more dependent on baby's needs. If the baby needs to have the need for maintaining temperature, then of course it needs to be on, but there is no mandate that it has to be on. It can be turned off. There is one other question, and it could be for anybody. And the question is, first COVID death in the United States was apparently in a patient with ventricular rupture, and that patient was from Bay Area, California. Is that true? I guess anybody can take that up. There are no takers for that question.
Great question.
Okay, we will leave it at that. And there are just one or two more questions, and then we'll wrap it up. One question is there a need to include pulse oximeter reading into CPR guidelines in the context of COVID-19? Anybody can comment on that.
So the one aspect of pulse oximetry that it's really more in our institution, we have worked very hard to send more patients out with pulse oximetry to prevent cardiac arrest. I've been, it hasn't been brought up at this conference, but I've been very impressed with how hypoxic patients can be with minimal symptoms. And I can't help but think that there are people that have been sitting at home for days at a time, not realizing how hypoxic they are. And then they present with a 60% O2 sat in our emergency department. And you wonder, if they had come in 3 days sooner, could we have prevented what transpired after that, which is, having to be put on a ventilator and go to the ICU and in many instances death. So I think the biggest role for pulse ox in my mind is prevention, and more monitoring at home and checking in on patients more often. We have medical students now that are calling patients to check up on them. If they have a pulse ox with them, they can check on the pulse ox.
Thank you very much. And it's just about 8:30 right now. We can wrap this up, and I will turn the podium back to Dr. Murthy, who is the coordinator. And if Dr. Suresh Reddy is still on, he can make the final comments. Dr. Murthy or Dr. Reddy?
Yeah, thank you, Dr. Vasa. I think, this concludes the program, and hope you all enjoyed it. And I would like to thank all the eminent speakers, our moderator, and our leader, Dr. Suresh Reddy, for providing this high quality program. And I was told that in the near future, AAPI and the Chicago Medical Society will be collaborating to provide high quality programs. You just witnessed one, and I'm happy that hopefully I'll be a part and parcel of it. So the most important message you already received, from the eminent speakers, and my message to you is, before I leave you, is, take care of yourself first. Thank you. And this concludes the program.
Thank you, everybody. And please join. We are organizing the first ever virtual summit in the last week of June. And we have Dr. Murthy has organized 8.5 hours of CME. And we have several events going on, including a CEO forum, women's forum, quiz, spelling bee, and medical students quiz, poster presentations. We have a lot of things going on. Please join us, and thank you again for joining.
Thank you all.